Okay,
thank you. Very good evening, all respected doctors. I am Dr. Kunal Javeri from Zydus Medical Team. And I once again welcome each one of you for the today's scientific webinar, which is known as a Bemtalk. Dear doctors, as you know that for management of dyslipidemia, statins are always considered as a first-line therapy. And they are very, very effective drug to reduce the CV outcome by reducing the LDL. But there are some cases as well, and the prevalence of uncontrolled dyslipidemia, focusing on uncontrolled LDL-C, it is also present in routine clinical practice. So to control that, we have recent molecules which are approved by various authorities and also approved by DCGI. So to discuss on that, what are the new therapies are available for uncontrolled dyslipidemia patients, we have invited very renowned and very senior interventional cardiologist, Dr. Soumitra Ray from Calcutta. Dr. Soumitra Ray is a director of invasive cardiology from AMRI Hospital, and he has a vast experience in not only cardiovascular therapy, but also teaching as well as the clinical research in cardiovascular therapy area. So without taking much time, I would like to invite Dr. Soumitra Ray, sir, to taking the session further, and he is going to enlighten us on recent therapy area for the uncontrolled LDL-C. Thank you. Sir, it's over to you, sir.
Thank you, Dr. Javeri, and good evening, and welcome all the delegates who have joined us this evening. Let's see one thing. Can you see the full screen?
Yes, sir. It
okay.
is our screen.
Okay. So let's go ahead. As Dr. Javeri has already explained, we are here to discuss about the new molecule entry in the Indian market, that is bempedoic acid. Its positioning in the management of dyslipidemia. Now, we know that it's very traditional over now more than 30 years. We know that dyslipidemia is a major concern for cardiovascular event, irrespective whether it is a primary prevention setting or a secondary prevention setting. And of course, the gray zone between the two. So there was a publication long time ago, about 18 years ago, by Salim Yusuf in Lancet, that irrespective of primary or secondary prevention, it was proved in around 15,000 odd patients and about 15,000 control in 52 countries in the world. It has been shown that population attributable risk, adjusted for all risk factor, lipid dysfunction was highest, followed by smoking and psychosocial factor. Much less in the list coming obesity and hypertension. Even lesser are diet, exercise, alcohol, and diabetes. And they said that if these 9 risk factors are controlled, 90% of heart attack or MI could be prevented. And by the lipids, they actually clarified as ApoB by ApoA1. Simply speaking, LDL by HDL ratio. So if you see, there is some not conforming with the traditional value that hypertension, diabetes, obesity, these are rather less important than smoking and psychosocial factor, which is still neglected. Now, if we come, why this dyslipidemia, and particularly controlling dyslipidemia with statin, is so very important? Because in the primary prevention setup, in the about 25, 30 years ago, there are loads and loads of data came from all over the world, like AppCaps, AllHat, Ascot LLA, CARDS, Prosper, Jupiter more recently, and they all showed in adult patients, and very interestingly, if you see the age cutoff, the lower age cutoff was 40. That's why most of the guidelines are still a bit hesitant to recommend cholesterol lowering below the age of 40, because the data is not that philosophically or ideally they should not be done, but there is some lack of data in the 20 to 40 age group. The same is above 75 to 80 years of age group. So again, the guidelines are slightly on the back foot in recommending statins in this elderly population. And the main results were different kinds of results, which includes cardiovascular mortality, all-cause mortality, non-fatal infarct, non-fatal stroke, hospitalization with angina, and so on. And almost everywhere, and they're a good follow-up, around 4 years on an average. And almost everywhere they showed a significant favorable result for statin compared to placebo. If you see more trials on secondary prevention as opposed to primary, you have got even more renowned trials like 4S, Lipid Care, Miracle, Lips, Prosper, Prove It TIMI22, TNT, Ideal. Now these last three, Prove It TIMI22, TNT, and Ideal, are statin versus statin, high dose statin versus low dose statin. And the first 6 are statin versus placebo. So statin versus placebo, they showed an uniformly approximately 30 to 35% reduction of LDL cholesterol, which translated into clinical benefit in terms of mortality as well as non-fatal MI reduction, be it with pravastatin, be it with simvastatin, atorvastatin, or fluvastatin. The last 3 trials are more interesting, where they have proved that high dose statin, say atorvastatin 80 versus pravastatin 40, or even atorvastatin 80 versus atorvastatin itself at 10, or atorvastatin 80 versus simvastatin 20, with more rigorous lowering of LDL cholesterol, you get incremental benefit in terms of cardiovascular endpoint. So actually, if you see the number of patients in the both primary and secondary prevention trial, this is almost 80,000-90,000 patients now in the trials, almost 1 lakh patients in the trial, all of which showed benefit in favor of statin, particularly also in high dose statin in secondary prevention. But there is some but remains. One but is that all statins are equally effective. They are not. Not all statins are equally effective. As we have seen, the molecule to molecule, there is variation. There is dose variation. Some have got some effect on HDL, on triglyceride. Some do not have that effect on HDL and triglyceride. So there is some variability or heterogeneity in the statin class. And more important but is that even when you trigger the highest dose of statin that is recommended or the patient can tolerate, and your LDL is beyond the target, what to do? That remains the more but nowadays. So if we address the first concern, do all statins are equally effective? And if you see that relative reduction of 40 milligram of LDL, that is about 1 millimole of LDL, there is 23% of relative risk reduction. But we know that LDL is better if lower. It has been proved that with other methods, both pharmacotherapy like PCSK9 inhibitor, like surgery like ileal bypass, or with other medicines, if you can reduce cholesterol further, you get more benefit. So whatever you achieve with cholesterol may not be the last word. So if you see the target as is changing with time, in the same continent, in the Europe, it has changed within 3 years from 2016 to 2019. And in the very high risk group, the target came down from 70 to 55. In the moderate or high risk group or in the low risk group, everywhere there is a reduction of target. Only in the low risk group or in the primary prevention setup, the target remains 115. So as the cardiovascular risk increases, our target goes down and down. And you can understand that achieving 100 milligram LDL is relatively easy in your day-to-day experience. Achieving 70, you need a little bit of effort going to highest dose of statin. But how many patients you can really reach below 55, even with the highest recommended dose of statin? In our personal experience, the percentage is not very high, certainly not beyond 50%. Now, if we go by this guideline, how many patients we really can achieve these targets? So there was an observational study which was published recently. The therapy used in secondary and primary care, the Da Vinci study. This came from Kaushik Ray of UK, that a cross-sectional observational study of patient prescribed LLD for primary or secondary prevention. And 18 countries of Europe were involved. About 6,000 patients were taken. Half of them were primary, half of them were secondary prevention. And they tried to find out the impact of this 2019 guideline on the achievement of target. And what they found is very interesting. Da Vinci study published only last year in European Journal of Preventive Cardiology. Proportion of patient receiving LLT, low intensity about 3%, moderate intensity about 50%, high intensity about 27%, AGT-MIBE in around 10%, PCSK9 about 1%, and some other medicine in around 5-6% cases. And how many are achieving goal? Overall, if you go by the 2016 guideline, around half of the patients are achieving goal, not beyond 54%. But if you make the target more stringent, like 2019 guideline, then from half it becomes 1/3 straight away. Same patient, same medicine, but if your target milepost changes, your failure rate increases from 46% failure to 67% failure to achieve the target. Even with high intensity statin, the red bars, 2016 guideline achieved around 53% target. And 2019 guideline, only 1/3 of patients achieved. What I was just telling 2 minutes ago, that even with highest dose of statin, in your day-to-day experience, how many patients you see have gone LDL below 55? So it proves that it's not more than 30%. If you give PCSK9, then perhaps you achieve something more. 60 to 70% of patients achieve their target. But even then, 30% patients do not achieve their target, even with the best possible medicine combination, so costly, available in the market. In the very high risk ASCVD group, still you see only 37% of patients who are getting high intensity statin. More number of patients are getting moderate intensity statin. This is not a village practitioner in a remote part of India. These are European country physicians who are supposedly so learned, so exposed to the modern medicine, so motivated. Even with them, even in the very high risk ASCVD, 43% of them are giving only moderate intensity of statin. So that is a very sorry state of affairs, clinical inertia. But even when this 37% of patients, they are getting the high intensity statin, how are they faring? Only 45% are achieving the LDL target of 55, of 70 by 2016 guideline. And if you reduce the target to 55, as is the latest guideline, then only 20% of patients, even with the high intensity statin monotherapy, are achieving the target of 55. If you add ezetimibe combination, very funny, from 22 it becomes 21. That means ezetimibe is doing nothing in achieving the target of 55 milligram per DL of LDL in the highest risk population patient. Yes, of course, if you add PCSK9, the figure jumps from 20% to 60%. This is a real game changer, but lo and behold, you can't afford it. How much is clinically beneficial to attain LDL-C? These goalposts, are they really unachievable, unattainable in our lifetime? Target LDL and secondary prevention for patients with AMI. A Korean study published only this year, 2 months ago, in the Journal of Clinical Medicine. 5,000 patients who had AMI in the past. How do you define their LDL achievement? Patients who achieve an LDL decrease of more than 50% from the baseline. And now it is below 70. So you have to fulfill both the criteria. They're 70, they're quite generous. They're not giving 55, they're giving 70. Quite a giveaway. Study endpoint was 2 years of major adverse cardiac and cerebral event, including mortality, recurrent MI, recurrent stroke. And they followed up for median 2 years. And what did they find? The 94% were on moderate to high statin. Again, moderate. I'm sure that moderate was 50% and high was 44%. LDL achievers was only 22%. Only 22%. Exactly the same figure as the Da Vinci study reproduced in Europe. It is reproduced in Asia now. With relative risk reduction of MSCC in LDL achievers is 37% who has achieved compared to who did not achieve. And it was a significant difference of 37% reduction if you can achieve. So it is not an academic discussion. If you can really achieve 55 LDL after an MI versus if you cannot achieve 55 after an MI, you can accrue a 37% benefit of further event within next 2 years. You don't have to wait for 20 years. Within 2 years, you will get the benefit of 37% reduction. So you need to achieve this target. It is beyond any argument, beyond any doubt or suspicion. Now, primary endpoint according to the achievement of either target LDL, major adverse cardiovascular event, follow-up after index MI, LDL below 70, and reduction more than 50. So you achieve both the criteria. Then your incidence is, after 3 years, is 2.3%. If you achieve either of the criteria, then it is around 3.4 to 3.9%. And if you achieve neither, then it is around 4%. So 2.3 versus 4%. And if you see what is more important to achieve LDL 70 or reduction more than 50, they're more or less similar. Perhaps LDL below 70 is more important than reduction of 50 because absolute value is important. Say your baseline LDL is 200 and you have achieved 90. So you have achieved more than 50 because from 200 to 90 is more than 50. But you did not attain 70 milligram target. So you're not doing so well. Rather, if you achieve 70 milligram, but did not achieve 50% reduction, perhaps you are same. But of course, if you achieve both, then you have got half the incidence. So that is number one. Number two issue is how to achieve LDL-C target once you exhaust your statin armamentarium. ESC itself says that with moderate statin, you average. It is not mathematics, but biology. So average LDL reduction is around 30%. With high intensity statin, it is around 50%. If you add ezetimibe, it's another 15%, not too bad, 15%. Only PCSK9 alone can reduce 60%. But if you give on top of statin, it is 75%. And if you give PCSK9 with statin and ezetimibe, then it is 85%, which is the maximum you can think today. That is a sort of rough guideline they have given. Now, in this algorithm, how we place the new molecule, bempedoic acid, which is an ATP citrate lyase inhibitor, or very simply ACL inhibitor, ATP citrate lyase inhibitor. It is the only molecule in this class. It is approved in USA, EU, and now in India. In 2020, it was approved in USA and EU. Now it is approved in 2022 in India. And there are two indications. One is uncontrolled LDL-C with maximum dose of statin tolerated, or with mixed dyslipidemia, familial hypercholesterolemia with high risk of ASCVD patient. And the second indication is statin intolerant or statin contraindicated. Dose is very simple, single dose, no adjustment needed, 180 milligram oral dose. Before or after food, it does not matter, any time of day or night. How it works? It works at a step when cholesterol is produced. The citrate by ACL and HMG reductase cholesterol synthesis pathway. They haven't given the 7 or 8 pathways, just the 2 major areas. Statin inhibits HMG-CoA reductase, and bempedoic acid inhibits ACL enzyme. So it is actually 2 steps above statin. So you may say that if you reduce the pathway, block the pathway at level of ACL, will statin work further? Because statin won't get the enzyme HMG-CoA reductase. So whom it will inhibit. Actually, it has been shown that these are not very rate limiting steps, and there is always some leakage, always enough ingredient for the statins to work even after bempedoic acid. And bempedoic acid is actually complementary and additive to statin effect. It has been shown and proved in patients and in animals. Now, bempedoic acid is actually a prodrug. It becomes bempedoil-CoA. This bempedoil-CoA production occurs by ASCVL1, an enzyme which is present only in the liver. So in any other part of the body, bempedoic acid might go and visit that organ, but that organ will refuse bempedoic acid to take up. They will say, oh, you don't have the enzyme to convert you to your active drug, so go away. So bempedoic acid is basically worthless, either good or bad, in any other part of the body, excepting in liver. So it is very liver specific. So whatever good or bad it does in the liver, excepting one or two rare exceptions. In the skeletal muscle, bempedoic acid is slightly changed. There is a little enzyme over there. So skeletal muscle is the second organ where it may work. And that's why one of its concerned side effect, just a minute. Now, so in the skeletal muscle, it might have got some side effect like biceps rupture, or in the kidney, it might have some effect. How do we do the tips and tricks of bempedoic acid treatment? Half-life is around 21 hours, so it is a long-acting drug. Eliminates 70% through kidney, only very little in the stool, and it's usually not unchanged. It is fully converted. When we can give it safely, if there is renal impairment, no dose adjustment necessary, excepting in end-stage renal disease, where it is not yet studied. And in liver disease, again, no dose adjustment required. But again, in the advanced disease, Child-Pugh class C, that is the last stage, it is not studied. So end-stage renal and liver disease, it's not studied. But in all other grades of renal and liver impairment, you can give the same dose of bempedoic acid. When you have got a little concern, you need monitoring. Uric acid should be monitored. It's a good clinical practice to check the baseline uric acid or ask the patient for history of gout. If the baseline uric acid is above normal or near above normal, or there is history of gouty attack, you be careful and you have a close monitoring of uric acid. Prior history of gout is the same. Third point is elderly patient taking steroid or fluoroquinolone who are renally impaired and a history of tendon rupture. So a elderly person with renal failure on steroid and a history of tendon rupture, which is very rare in our clinical practice. We haven't seen a tendon rupture, spontaneous tendon rupture. Of course, you have tendon rupture on injury or road traffic accident, or spontaneous tendon rupture, I've rarely encountered. Maybe the rheumatologist and orthopedicians see them. You warn these people for potential for tendon rupture and advise these patients to rest at first sign of tendinitis or tendon rupture. So this is very important. You must counsel the patient in this, not all patients, but these elderly, renally impaired patient on steroid, etc., you tell them, if you feel any muscle pain anywhere in the body or joint movement pain, particularly in the elbow, shoulder, etc., you immediately go to rest, stop taking bempedoic acid, and contact your doctor. And there are certain situations when you have to stop bempedoic acid. Who are those? Same patients, elderly patient with steroid or fluoroquinolone with renal failure and history of tendon rupture. When they have a tendon rupture, you immediately stop it. Or if the patient comes with a joint pain, swelling, or inflammation, whatever be the reason, you might think and find out later on, but you stop the bempedoic acid immediately. Number 2 group of patient which is not relevant is simvastatin taking more than 20 or pravastatin taking more than 40. None of them are available in India, but sometimes you get patient from USA or Dubai, and I have seen patients on simvastatin who are coming from America. So be careful, you don't start bempedoic acid on them if their simvastatin dose is more than 20 or pravastatin dose is more than 40. In pregnant patient, but it is a relative contraindication because they have got very few options for dyslipidemia in pregnancy. Statins are contraindicated. Niacins are contraindicated. You might give cholestyramine, very messy drug. And breastfeeding. So pregnancy, breastfeeding, unfortunately, have been excluded for most clinical studies, so there is no data. Only fortunately, these are temporary events in a patient's life, few months. So perhaps you can tide over without anti-lipid medicine. And there are data being gathered on bempedoic acid. Either they are ASCVD patient or they are familial hypercholesterolemia heterozygous. Homozygous usually don't come under clinical studies. And their names are very catchy name or are clear. Clear harmony, clear wisdom. These are patients who are already on statin, maximum dose of statin that they could tolerate. And clear serenity and clear tranquility are patients who are almost on no dose of statin because of either contraindication or side effect. Clear harmony and clear wisdom are 1-year studies. They are ASCVD patients. Many of them are hypertensive and diabetic. Clear wisdom is a smaller study. Again, all of them are ASCVD patient with hypertension and diabetes. Clear serenity is 6-month study and clear tranquility is 3-month study. Clear serenity is small study. Even ASCVD is small, lesser number. And clear tranquility is because you get less number because you get very few patients who cannot tolerate statin. It is not a very common experience in your or my practice. Statin intolerance is really very less. Real intolerance is really very less. So you don't get thousands of patients. You may get a few hundred patients if you look around on different countries. And they are hypertensive and diabetic. So clear harmony and clear wisdom, as you see, that the maximum dose statin patient, and all of them are ASCVD patient, 1-year study. They are all on high or moderate dose of statin. Percentage reduction of LDL is the primary endpoint for efficacy and overall safety at the end of 1 year. And they showed that LDL cholesterol, from an average value of 100, it becomes 88. It's around 10% reduction on the maximum statin. Not bad. On HDL, there is a little effect. Non-HDL, ApoB, they're all parallel. And there, fortunately, p-values are significant. Even at the end of 12 weeks, that means around 3 months. Ultimately, there is around 17% reduction of LDL, which is a significant p-value. But there is no difference in HDL, no difference in triglyceride, no difference in LPA, but CRP reduces. Clear tranquility and serenity, which are statin intolerant patients, but some of them have got low dose of statin, around 30%, 20 to 30%. And again, the same efficacy and safety endpoints. And here you see that there is a very good result without statin. On statin, there is a 10% reduction, but without statin, there is a 23% reduction of LDL cholesterol, which is pretty good, pretty good. And you might achieve your target in a good number of patients. Clear serenity also showed the same thing, 23% reduction if there is no statin as a baseline. Now, there is some trial, bempedoic acid or ezetimibe, separately or fixed dose combination. We have shown that alone ezetimibe can reduce LDL by 23%. Alone bempedoic acid can reduce around 17%. And when they're combined, you can see a very tremendous result of 36% reduction. So now you see, if a person is totally statin intolerant, and if you can give a ezetimibe bempedoic acid combination, there's a 36% reduction. So your 100 LDL becomes 60 LDL. Your 90 LDL becomes 55 LDL, which was unthinkable a few years ago. We thought there's no hope for these patients who have got a heart attack, stroke, atherosclerosis, and their cholesterol is 90, 100, and they cannot tolerate statin. Oh God, what to do? Now you see, in majority of these patients, now you can achieve a reasonable cholesterol reduction, if not the exact target. Clear outcome trial is going on, which will specifically see if there is cardiovascular benefit with bempedoic acid. 14,000 patients. They will stop recruiting by the end of this year. And we'll be very excited to know the result, and we'll be very happy, neutrally, unbiased way, if they can produce a significant result, which will change the prospect of many patients, many poor patients who feel frustrated and who feel hopeless. ADA 2022 mentioned bempedoic acid as lipid-lowering agent in high-risk patient. What about other risk markers? The bempedoic acid, along with LDL cholesterol, can reduce inflammatory marker. As I mentioned, it did not touch triglyceride, VLDL, or HDL, but it did touch C-reactive protein and other inflammatory markers. So if you see bempedoic versus placebo, hsCRP is fantastically reduced to the tune of 20 to 30% in these 4 trials variably. So again, when statin is on, Clear Harmony and Wisdom, there is around 20% reduction, because statin does the job already. But when there is no statin, the reduction is almost 30%. So you can see that, of course, on statin, bempedoic acid's efficacy reduces, but it's still a worthwhile reduction. And without statin, it's really a champion. What about the adverse event? Hyperuricemia, more, 3 times more, but total number is less, 1.7%. Gout is again 4 times more, but again the total number is 1.4%. But if you see liver enzyme, no difference, anemia, no difference, tendon rupture, again, these trials did not see any p-value. But as these are very sensitive issues, even without p-value, you have to be careful. Now, the bad part of statin, particularly high-dose statin, is diabetes, new onset diabetes, which is rather significantly less with bempedoic acid, even compared to placebo. Now, here is a food for thought, how bempedoic acid is protecting against new onset diabetes. What is its mechanism of action? Does it act on pancreas, muscle, liver, which pathway? I think future days will give us the answer. At the moment, this is only an observation, and it's a welcome observation. Because if the potency of statin for new onset diabetes can to some extent mitigated by addition of bempedoic acid, that will be a welcome addition. So I stop here, friends, by saying that uncontrolled LDL-C is the most important cause of cardiovascular disease. Statin and the highest dose of statin, highest possible dose of statin, should be employed to achieve the target for that particular set of patients that you are dealing with. But even after that, 70% of patients did not achieve target, which translates into 60 to 70% increase in the residual cardiovascular risk. Bempedoic acid is the first molecule in a new class of ACL inhibitor. There is about 20% reduction on top of statin and 30% reduction when there is no statin. It is safe in kidney and liver failure, unless they are the terminal failure. High uric acid, gout, and tendon rupture should be monitored, and patients should be cautioned against it. I thank you over here, and I'm open for discussion and your suggestion, your experience sharing, and everything.
Okay. So thank
Dr.
you.
Kunal, yeah.
It was a
I can
really
hear you. I can't hear you.
wonderful session, and definitely what you have portrayed there. Yes, sir. So am I audible? Am I
Yes,
audible now,
now
sir?
you're audible, but there is some noise disturbance. Everybody else should mute themselves,
I
except
think,
in
sir.
who's talking.
Yeah. Just one minute, sir. Now it is fine, sir.
Yeah, it's fine. Good.
Yeah.
Any
So
question
thank you, sir.
coming in the chat box? Yeah.
Yeah. So there are some questions are there. Definitely, the majority of the questions are already answered by you. But one question is that one of the Dr. Jain, who is asking that after statin, we have ezetimibe as well, and we have bempedoic acid, and we have PCSK9 inhibitor as well. So if I want to choose out of these three drugs, then how to position?
It depends on two things. Number one, the patient's target versus achieved LDL disbalance. And number two, patient's socio-economic condition. If the target is far away after statin, then perhaps you have to recourse to PCSK9 inhibitor, if the patient can afford. But the problem is that in 9 out of 10, even 99 out of 100 cases, the patient cannot afford. Even if they can afford a few injections, they cannot continue it beyond 6 months or 1 year, then it loses its efficacy. It doesn't make any sense. So you have to be pragmatic. You can go step by step. Ezetimibe has got more trial at the moment, outcome trial, Prove It TIMI-22. So perhaps you will give ezetimibe on highest dose of statin first. And if the respective target of 55, 70, 100, and 115, these are the 4 LDL targets for 4 different sets of patients. If they're not achieved, then I'll go for bempedoic acid before embarking on PCSK9. Because if you, with ezetimibe, bempedoic, and statin, if you can achieve your target or near target in a good number of patients, then the need of PCSK9 inhibitor is not there. Patient feels good, you feels better. There's no itching in the conscience that my patient cannot afford. The drug is available in the market, but the patient cannot have it. That is a bit of an uncomfortable feeling on the part of clinician as well as the patient. So I think it's always worth trying without waiting much, both the drugs of ezetimibe and bempedoic acid. And you know the fixed dose combination is available in America. So they're encouraging to give them together without going for a step care approach. So if your statin does not achieve the target, give a combination, because you know what will you lose by giving the combination. At most, the LDL will be much lower. And nowadays we know lower is better. So you don't have to stop by just going below 55. If by going below 55, why do you stop at 50? If by ezetimibe bempedoic it becomes 35, it's even better. They have said that your minimum target is 55. But below that, you can go even up to 20 if you can achieve it easily without much side effect, without much budget. So it is proved by various trials, by the Orion group of trials, by Prove It trials, by Jupiter trials, that 20 is better than 30, 30 is better than 40, 40 is better than 50. You get incremental benefit. With each 10 milligram decrease of LDL, it has been shown up to 18 milligram that you get incremental benefit. So by giving ezetimibe bempedoic at one go, if your LDL falls to 40 instead of stopping at 50, it's a welcome situation. So I would say for every patient whom you are thinking going beyond statin, you should give ezetimibe bempedoic acid combination without hesitation. You are mute, Dr. Kunal.
Sorry. So, sir, I think the answer for the next question already, sir, you have portrayed that. Dr. Hazra is asking that how much LDL has to be reduced. Means depends on definitely severe target.
As
up to what level we can reduce the LDL?
Up to 18. I mean, without taking side effect, without pinching on the pocket of the patient, then you might ask me, why don't you give evolocumab to everybody? You will achieve 20. As I mentioned, you have to be patient friendly as well. So if in a reasonable way, with a reasonable cost, you can achieve 30, 35, it is good. You don't reduce the dose to make it 40, 45, or 50 because the minimum target is 50. That is my contention of saying. But don't, if you're with all these three things, you have achieved 50. Now you told that 18 is better than 50, so why don't you add evolocumab? Because it's not practical. This is not practical. So you have to make a balance between the benefit you are thinking and the cost you are doing. Because patients don't take it. They would curtail the cost on other things, on other medicines, maybe by taking an evolocumab. So ultimately, you have to be a good clinician and judge of your patient. What I am saying, if by giving ezetimibe and bempedoic acid combination, which is a reasonably cheap combination, not a very much costing on the patient, and you achieve below 50 low down, you accept it. You accept it. It's good for your patient.
Yes, definitely, sir. Sir, one of the question is now on statin intolerance that you have shown that this drug has also some improvement in statin intolerance patient by LDL reduction. So the question is that in real world practice, how many times that we are encountering the statin intolerance cases and where this drug is going to be useful?
This is very rare. As I mentioned in my talks, real statin intolerance is very rare. That SMS, that the muscle symptoms are basically vague symptoms. They are not real statin intolerance. If there is muscle symptom, you first examine the patient clinically whether the muscle is tender or not, and then always do a CPK enzyme. If the CPK is dead normal, then you just reassure the patient, give vitamin D, give whatever, vitamin E, some body massage, whatever you want, you give, but you continue with statin. One question comes, and the second is diabetes. It is there, real, but you take that. You don't shun away from statin because there is a 5% increased risk of new onset diabetes. The third is liver. Actually, people are nowadays saying that if the liver enzyme goes up with statin, you rather see whether there is other liver problem, primary liver disease, not the statin is the culprit. But well, if it is more than 5-10 times, you have to be careful. Cataract is not there. Neurocognitive impairment, it has got paper almost every month. 1 month says there is no evidence. The second paper says yes, some evidence. Even yesterday, there was a paper saying that yes, there is neurocognitive impairment with statin. We should be careful. Came from America. So there, and the editors say that we should very carefully interpret these results. So there is always there. So I don't go, but people don't do suicide on statin. What happens is that there is a overzealous physician attitude I am encountering after bempedoic acid. They are saying, then we'll give a lower dose of statin and add bempedoic acid. Now that is not the right strategy. That is not science. You go to the highest dose of statin as the patient can tolerate. Just by fancying that why should I give the highest dose of statin may cause side effect. So why don't I give a little bit of statin, little bit of bempedoic, a little bit of ezetimibe? No, there is no evidence for that as yet. So don't do that practice to promote bempedoic acid. You have to have genuine statin intolerance at a particular dose. Then only you reduce that dose and add bempedoic. Just because bempedoic acid there, you reduce your atorvastatin from 40 to 20 and add bempedoic acid to top up or to supplement. Don't do that. That is not the recommended practice at the moment.
That's rightly said, sir. So just last question that I would like to ask here, that though this drug, bempedoic acid clear outcome study is still ongoing for the CV outcome benefit. So what is the scope that this drug is going to be recommended by international guideline in future, so that more doctors can have a conviction about this?
Yes. Now I ask certain things like your own company makes saroglitazar. Okay. And there is no outcome data as yet. But I'm such a fan of saroglitazar. Don't you think that if your triglyceride comes from 300 to 100, it is good? I mean, why do you need evidence in everything? You can't get evidence on everything. When you reduce your blood pressure with cilnidipine or effonidipine, where is the evidence that it reduces mortality? But don't you feel happy that your blood pressure is from 150 to 130 systolic today with cilnidipine or effonidipine? Do you question the rationality of prescribing cilnidipine or effonidipine? Where is the mortality outcome? Where is the morbidity outcome? I don't understand why people have got different standards for pressure, sugar, and cholesterol. When we are talking about pressure, our target is 130 by 80. We don't care so much of what medicines we are using, maybe the groups, but not the individual member of the groups. There's no evidence in 90% of the members. Only 10% have got evidence. While reducing diabetes, we are talking about the HbA1c level. Of course, with other benefit, cardiovascular benefit, heart failure benefit. There are things, but we are not talking about that show the mortality benefit with this new class of medicine. Otherwise, I won't use it as an anti-diabetic. As long as it reduces my sugar and makes the HbA1c 7%, I do not question its efficacy. So why do I shoot the question of efficacy of bempedoic acid and wait for the mortality trial to prove its worth? When the ESC says your target is 55 LDL cholesterol, they did not say that 55 LDL with statin. They did not put it in the same bracket. They said 55 LDL cholesterol. It's your job to reduce it, however you reduce it. You can reduce it by plasmapheresis. They didn't mention anything. They said in this group of patients, I need below 55. So why should I wait for an, I don't know. I don't care about the clarity, the clear outcome trial. I really don't care. Even if it is a negative trial, my conviction won't change that I'll try to reduce LDL cholesterol to 55 in my heart attack patient. And if the statins and ezetimibe fail, I'll try bempedoic acid. Nothing can stop me.
That I think it's perfectly right. I think we have discussed also in one of the webinar, the doctor was saying the same that where we should think majorly about the marker rather than always think about the cardiovascular outcome.
Yeah.
Because once its marker is reduced, for example, LDL is reduced, anyways, that drug is going to be benefited for the patient. That is the actually our should be target rather than
when you are drawing
about
that
the
curve of reducing LDL is reducing event, you saw there are all types of things were there, including plasmapheresis, including nicotinic acid, cholestyramine, including ezetimibe, including PCSK9. Whatever be the method you employ, if your LDL is reduced, you get clinical event benefit. You may or may not show it in the trial because of the trial design, because the statistical jugglery, because of the type of patients, baseline medicine. So many things happen nowadays. Nowadays, with the modern medicines, it's very difficult to get an incremental benefit for mortality. People don't die nowadays unless there is an accident or they don't take drugs. They're negligent about that health. They don't see doctors, don't take drugs. If they see a doctor, good doctor, and if they take the drugs, they don't die. That is the problem.
That's true. That's true.
Too many elderly people nowadays in the society. You can see that. Our average is increasing like anything. Every family there is problem what to do with the elderly people, how to handle them. There is no infrastructure.
That's true. Correctly said, sir. So I think that was a wonderful discussion and a very interactive elaboration from your end. So if I conclude your message to everyone that yes, dyslipidemia has to be treated aggressively and depends on the target as much as LDL if you can low, you can reduce, that is always in the benefits for the patient. After statin, you have multiple options, but yes, ezetimibe, bempedoic acid is definitely good to go because of the cost effectiveness as well as the overall effectiveness and safety of this molecule. And internationally, also it is now recommended very widely. So definitely we have to use it in a required patient manner as well. So, sir, with this, we would like to conclude the session.
Thank you.
And once again, on behalf of
Mr. Raja, nice to see you after some time. Thank you. Okay.
So thank you, sir.
See you, Dr. Javedi.
Thank you, sir. Have a nice day.
Again. Bye.
Thank you.
Sir, one
Good
second.
night, sir. Good night. Bye.